Hi, I'm Phil. Let's look at compliance with non-invasive ventilation today. Why is that so important? Well, there's a few reasons. Firstly, it decreases the length of stay compared to someone that eventually gets intubated and ends up in ICU. It decreases the risk of infections, respiratory infections specifically, by being intubated. The patient stays awake through the whole procedure or time that they're in hospital. And also, you don't need to wean a patient off non-invasive ventilation as long as you would a ventilator. So where do we start? We always start with a good assessment. So assess the patient. Are they cognitively able to follow commands? Now, they're not a healthy person if you need non-invasive ventilation, are they? They're going to be tired, they're going to have short of breath, they're going to be anxious, even a bit agitated and aggressive, start plucking at things, pulling things off. But if you can focus them by speaking loudly and clearly to them, to their face, and you're the only contact with them, it does improve your compliance because they'll follow your instruction, and that's what you need to achieve. Them to follow what you need to say to them. So make sure you get good and clear instructions to them and that they can follow that. Other things with assessment is look at the shape of their face and the skin around their face. Will they take a mask on? Have they got a big beard that's going to create a lot of air leaks? So we've got to take all these sort of factors in consideration. Can you sit the patient bolt upright so they get the best lung expansion? Or is something impeding them when they have to be lying down further back? Other things to assess is the type of non-invasive ventilator you're going to use. Does it produce high flow air? So even if you do have a big leak, it will still be powerful enough to give you the pressures you require to adequately ventilate a patient. So now we've assessed that this patient can go on non-invasive ventilation. What's the setup? So we need a mask, we need some Duoderm or some good spongy fixing tape to the face because you get a lot of pressure areas around the face. You need the tubing, you need to check if it's 1 or 2 tubing. You need to make sure you understand the machine, the alarms are set appropriately to the patient and your starting volumes. You need to have the machine set with the starting volumes and also the pressures that you want to start at. Not all ventilators need oxygen flowing through them. Some will work just off air and just use pressure. So if you're out in a rural place and you've only got one left oxygen cylinder left but a few air, you can still give them air, but it's more advisable if you could get oxygen into them because that's really what they need. Initial settings of non-invasive ventilation to increase compliance. I like to set my pressures very low and just to get the person used to a mask. They're breathing very hard to start with. They're not cooperating too well with you. You're putting a mask on their face. If you start shoving hardcore air into their face, they're going to chuck it off. They're going to hate it and pull it away and become more agitated, more short of breath, and the whole cycle cascades. So explain to the patient, so we're going to start it off slowly, just low, gentle oxygen. Put it near their face. Don't strap it over their face straight away. Let them get the feel of it. Then after 2 or 3 breaths, secure the mask to their face firmly. Check that there's no air leaks. Make sure the patient's taking in nice, big, deep breaths and then increase your pressures as needed. And you'll find that the tolerance is much more improved. Positioning a patient, like I said before, the best position is sitting a person upright or even a little bit forward so they get good lung expansion. Also sitting a person up, because they have an increased air going in and into their stomach, they could aspirate. So they could get air into their tummy, cause a lot of pressure in there, vomit out, and then they aspirate it. So sitting them upright, you can actually take the mask off, lean them forward, and let them vomit out, and hopefully decrease the chance of aspiration. So when we fit the mask, when I always fit a mask anyway, I always put tape across the bridge of the nose, around the sides of the cheek and the chin, if I can. If it's a big bearded person, you can shave around the chin if you need to, or you can just get a bit of clear plastic dressing, put that over, and that can create a bit of a seal quite quickly as well. And then fit the mask over the patient, make sure it's sitting firm but not too tight that it's creasing every nose and cheeks, and put my hands around the edge of the mask and feel for air leak. Now, some masks and some systems have quite a bit of air leak, and it all depends what you have, but you want to try and minimize that to the smallest volume possible so you get good pressure into the patient and not just escaping to the outside atmosphere. I always like to take a patient's mask off about 20 to 25 minutes into the non-invasive ventilation, because it's very drying having that oxygen air shoved in your mouth continually. So I like to give them just a sip of water, not too much because otherwise they'll vomit. Just give them a sip, get a bit of lip balm, rub some lip balm around their lips, keep it all moist, give their face a wash. So I get a face washer or a flannel, give their face a bit of a scrub, clean their eyes out, get them all feeling a bit fresher, and then put the mask back on. You have to be assessing the patient, seeing if you do take their mask off, are they deteriorating because I'm trying to do this stuff? So these are the things you need to weigh up when you're doing it. But usually it will help increase the compliance of non-invasive ventilation. Once you've started getting the patient used to being on the ventilator, get them thinking about their breathing and trying to control their breaths as well, because they can have a bit of input, gives them a bit of control back and helps them to work with the machine and get better results. When a patient is on non-invasive ventilation, and if they are quite ill with it, you need to be with the patient all the time because of the risk of aspiration or the patient deteriorating suddenly. So it's one-on-one nursing, and it's very intensive. Usually it's a good feeling when you've worked all night on a patient like someone with pulmonary edema or something like that, and they've come in, they're pre-arrest, they're about to be tubed, but you've just said, can we try a bit of non-invasive ventilation? You've worked hard all night and you've got them through to the morning where you've got them back onto a Hudson mask, say, or off non-invasive ventilation. It is a good feeling to achieve that goal. Doesn't always happen. There are people that will need eventual intubation, but just that bit of extra attention, a bit of extra care, and you can get them over the line. It is really rewarding, and also decreases their length of stay, so they're not in hospital as long, decreased chance of infections, they get home better, less need for rehab, and they can get on with their lives. So what do we take away from this video? Don't forget, the people receiving this are severely ill, respiratory distressed people. So there is a good chance that they do progress onto ventilation, but what we're trying to provide is an opportunity to give them the chance for their body to recover enough so they can start breathing on their own and fly again. Also remember, it is very labour intensive. You need to be with the patient all the time, but don't forget there is a good reward at the end trying to stop a person being ventilated. Look forward to seeing you soon.